The session this morning is on infection and oncology, and we have no oncology papers. It's purely no infection papers. It's purely an oncology paper, oncology session. This is for all of you to take home. Column and cord. Please collect your copy. It's available outside, I've been told. So please do collect your copy. So the first paper is for today is on solitary bone plasmacytoma of the spine, a systematic review. Unfortunately, Veronica has not been able to make it, so her colleague Ahmed Hassan is going to present this.
Good morning. My name is Ahmed Hassan. I'm one of the spinal surgery fellows at the Center for Spinal Studies and Surgery at Nottingham University Hospitals. Today I'm presenting our work regarding the solitary bone plasmacytomas of the spine. It's a systematic review. This is my conflict of interest disclosure. Nothing is related to this talk. So, generally speaking, plasma cell neoplasm comprise a wide array of disorders, ranging from the most common one, multiple myeloma, to the slightly less common ones, solitary plasmacytomas, which are divided into mainly extramedullary and solitary bone plasmacytomas. And we decided to conduct like a systematic review on the solitary bone plasmacytomas of the spine as a separate clinical entity. The aim of the study was to evaluate the current available literature on the mainly focusing on the clinical manifestations, surgical strategies, and the risk of progression to frank multiple myeloma in solitary plasmacytomas of the spine. So we conducted a systematic review based on the PRISMA guidelines. We searched 3 databases, PubMed, Cochrane, and Embase. We included studies of all patients older than 18 years old was diagnosed with solitary plasmacytomas of the spine. We excluded non-English articles, and we excluded the lack of proper cutoff point or differentiation between either this lesion was a proper solitary plasmacytoma or multiple myeloma. We used various free text forms and mesh terms with Boolean operators, and we finally included 17 articles. From those 17 articles totally encompassed around 2,000 patients. There was a slight male predominance of 1.75 to 1 male to female ratio at a median age of 55 years. For the clinical characteristics of solitary plasmacytomas of the spine, the most commonly presented in the thoracic spine, then followed by the cervical and lumbar spine, both by around 20–25%. The most common presenting symptom was back pain, followed by neurological deficit, and half of the patients with neurological deficit had motor weakness. Regarding different diagnostic modalities, serum paraprotein after plasma protein electrophoresis was only positive in 35% of the cases, which emphasizes the importance of doing a combined bone marrow biopsy and a biopsy from the solitary lesion. Regarding treatment options, the most commonly practiced treatment modality was radiotherapy alone, followed by radiotherapy and surgery, with the main aims of the surgery mainly for patients with neurological deficit, high SINS score, or failure of radiotherapy. The combined risk of progression for solitary plasmacytomas of the spine for this patient to develop multiple myeloma was 12%. And what we discovered that one of the predictors or of a good outcome, the presence of significant reossification after radiotherapy, where only 6.3% patients who showed significant reossification of the lesions following radiotherapy developed multiple myeloma, compared to 56% progression to multiple myeloma in cases of mild reossification following radiotherapy. So in conclusion, the main common presenting symptoms for solitary plasmacytomas is pain, followed by neurological deficit. The most commonly present in the thoracic spine. Most common treatment modality is radiotherapy with or without surgery, according to the presence of a neurological deficit or mechanical instability of the region, of the lesion, and there is a 12% risk of progression to multiple myeloma, so close follow-up is required for those cases. And thank you.
Thank you, Ahmed. Any questions from the floor? So I have a question for you. Given that a significant volume of these patients come in with only back pain, and the patient cohort are slightly younger as well, have you found any strategies where you can pick them up early? Because as we've discussed yesterday and heard the keynote speakers say, low back pain is a common presentation. It can come for various pathology.
The problem with these lesions are they only present like with back pain. Even the problem with solitary plasmacytoma, that the plasma protein electrophoresis is only positive in 30%. So in order to like formulate a designated pathway for this lesion is very difficult because it's a rare clinical entity.
And I suppose trying to achieve a curative treatment is the goal, given...
Yes, through radiotherapy.
Through radiotherapy. Yes. And did you find that there was a difference between recurrence from radiotherapy alone or radiotherapy and surgery? Was one modality shown to be superior than the other?
So although it is less practiced, combined surgery and radiotherapy has a less recurrence rate and less progression to multiple myeloma, but it's not the most commonly practiced treatment option.
Okay, so it's still radiotherapy is the first line treatment. Yes. And surgery is only indicated for three things you said: recurrence, instability, and failed radiotherapy.
Failure to respond to radiotherapy, which is mainly evidenced by lack of tumor regression and lack of reossification on CT scans.
Okay, thank you. Any other questions from the floor? Good. Yeah. Can you please come to the mic because this is being recorded? Thank you.
I'm confused by your data. It says solitary bone plasmacytoma.
Yes.
Okay. So you've got patients with neurological deficit, deformity. That suggests more extensive disease, does it not? What do you mean by solitary plasmacytoma? One vertebra?
One lesion in one...
One lesion?
One lesion.
One lesion?
Yes, a single lesion in the vertebra.
But could be as extensive as it...
It might extend, like involve more than one vertebral bodies, but mainly we're talking about a single lesion. It might extend to, for example, taking two vertebral bodies, but it's a single lesion, not multiple, like, or the patient doesn't have diffuse skeletal metastasis, for example.
I realize.
Okay.
But just to want to clarify how extensive.
Okay. We'll go there first. He's waiting. You first.
Hi. My name is Will Cato. I'm from Brighton. Apologies, I actually came in late, but I just wanted to know whether you looked at progression of instability with neurological deficits from patients who either had surgery and radiotherapy or radiotherapy alone.
So it wasn't one of the outcomes that wasn't one of the data that we're picking up from the from data extraction, and also the majority of studies are limited case series, so they will not follow up these patients for long enough time to detect instability or reversible instability.
All right, thank you.
Sarah.
In your surgical technique, you mentioned anterior and posterior. Did you use any cementing or just sort of?
Yes, it's usually used, especially in posterior constructs. but if it's mainly used if the main if the surgery is done mainly for pain.
Okay, we'll move on. Thank you.
Okay, thank you.
So the next speaker is Adnan Sheikh.
Morning, everyone. My name is Adnan Sheikh. I'm one of the locum consultant at St. George's, and I'll be presenting the oligometastatic disease, the current concept, and how we treat them and comparison with standard literature. By definition, oligometastasis is basically localized disease with less than 3 or 4 metastases throughout the body. Definition can vary between the oncologists, but broadly speaking, 4 to 5, maximum 6. Some people say 3, but that's average is 4. Then OMD management is basically radiosurgery like SBRT or SRS, or separation surgery with a stabilization, or tomita and block resection. So these are 3 standard. There has been a paradigm shift in treating the oligometastasis, or in general, the MSCC. Previously, it was radiotherapy. Then the patchel came, and the decompression fixation started. That improved the outcome. And then after the advent of SRS, we moved to a separation surgery from tomito and block resection. With SBRT, which is less invasive and low complication. This is an example of oligometastasis where we see only one vertebral body involved. It may have epidural extension, or it could be purely intravertebral. But broadly speaking, it's a single level throughout the spine with minimal tumor burden overall in the body. Now, the decision-making in the tumor in general, we all know about this, but just to cover, we first look at the Bilski score to know how immediately we have to act on it. If it's Bilski 3, we have to do the surgery quite immediately or on urgent basis. Then we look at the spine stability by SIN score. We apply that, and that's also a part of NORMS criteria, and that tells us about the stability of the spine. And then we look at the norms to see what kind of treatment overall is needed. And here is a Bilski scoring. 0, 1A, 1B is mainly in the body of the vertebra with very minimal epidural extension. But 1C, 2, and 3, there is more, and we have to do more. And in these cases, these are the examples where we do a separation surgery and then send them for SRS or SBRT. 1C, 2, and 3, we should be treating them differently, basically. And then this is the NORMS criteria. We all know about this. So basically, we look at the neurology, whether the patient has deficit or not. And then we look at the oncology, whether the tumor is sensitive or not, radiosensitive or not. Then we look at the stability, and then we look at the systemic tolerate surgery, whether the patient is fit for surgery or not, or they are very elderly or comorbidities. And based on this, if they're sensitive or not, we decide whether they're going for the SRS, SBRT, or surgery, or stabilization, or combination of all of these. In our study, we collected the data from 2017 till 24 last year. Identification of OMD, we searched through our database through the MDT data collected from all these years. We looked at the tumor time, analyzed the surgical techniques which were used in all this oligometastatic disease, and collected the mortality and data, like survival data. To pick up oligometastatic disease, there should be a proper pathway. So we have MDT with is chaired by different specialties, spinal surgeons, oncologists, radiologists, neuroradiologists, and then a nurse specialist. And we have a network of our hospitals around, so all the spine network, many people join the meeting to discuss their cases. And we have a very high index of suspicion to pick up these kind of cases because they can be easily grouped into the main group of metastasis where the tumor burden is high and the mortality and the survival rate is low because we need to pick them up early and high suspicion because they can be treated differently and they have a different survival and they are better survival. And the intention of treatment is curative or maximum resection so that they can live longer than usual MSCC cohort. So in our patients, there were 5,000 patients, over 5,000, and in the last 6 years, and we picked up 177 OMD cases. Initially, the percentage was 0.9 of overall MSCC referrals, but as we were more cautious in picking with a high suspicion, our percentage increased to 2.7 in 2023. We started picking up more OMD cases so that we could treat them differently. You can see the graph here. There are more cases are picked up. Now, most common tumor we saw was a renal cell carcinoma in OMD. For some reason, renal cell presents as OMD as early hematological metastasis, and if they have a scan, they are picked up as a solitary lesion, and we can treat them early with the maximum resection and curative intent, although it's not cure, but local curative. And then the other are breast, prostate, and lungs, and all the list. And also, if we want to send them for SBRT, there is a NHS England criteria or commissioning which says that they are eligible for SRS or SBRT only if it's a metachronous, not synchronous, because metachronous means they present later. If the breast cancer was diagnosed 5 years early and they had treatment, and now after 5 years the spinal mets is picked up, it's a metachronous. But if someone has a breast cancer diagnosed now and simultaneously they have multiple mets in spine and everywhere, it's a synchronous. So they have a poor prognosis, so they are not suitable for SBRT. And also we can see the disease in the metachronous, the 34% mortality in synchronous and only 15% in metachronous because they have a low disease burden. Management-wise, what we have done in our center is, so basically the aim, as I said early, is radical treatment, not palliative like Patchell before. Separation surgery is the most common surgery we do, which is done on 68 patients. Separation means we do decompression, we do laminectomy, we take the pedicles down bilaterally, and we go anterior and resect a part of the body as well. I mean, it's not a tomita resection, but for the radiotherapy to be delivered for the plant, they need at least 3 millimeters of clearance from the spinal cord so that they can plant the radiotherapy. So when we resect, we have to be very extensive in pedicle resection, going anterior, taking out all the tumor. Sometimes we use a CUSA to suck out all the tumor as well. And then we do carbon fixation. Titanium can also be done, but carbon is preferred by the oncologist because it helps into planning. There is a less, when they do an MRI planning, there is a less distraction of the images, and they can properly plan the radiotherapy dosing. If someone is having titanium, then it's acceptable, but sometimes for the planning, they might need a myelogram to see the clearance from the cord. Because myelogram is invasive and has its own risk, we just switch to carbon because it's easier for them to, there's a less artifact with carbon. Then initially, in early years, we did tomita more commonly because the SBRT referral was not streamlined. So we ended up resecting many en bloc resections. It has 30 to 40% morbidity. But eventually patient gets better, but now we have reduced tomita and we are more doing separation surgery. We have done very few decompression only without fixation because they were mid-thoracic. It was only pure lamina, no body involved. So we just did laminectomy and a bit of pedicle, and that removed all the tumor, and then we sent them for radiotherapy. Few patients who didn't have instability and no epidural compression, we did radiofrequency ablation or biopsy if they wanted, or kyphoplasty for the stability, segmental stability, and these were 19 in number. and they were all sent for radiotherapy after this. This is an example
So
of...
can we go to the conclusion? We're running out of time.
All right, okay. So this is an example management, again, non-surgical. This is our survival rate with different type of surgeries. On an average, 77% is overall worldwide literature. In our institute, we have got 91 at 6 months and 85% at 12-month survivor. So the conclusion is early recognition, optimum surgical strategies with separation and carbon rods and sending them for SBRT, and rethinking the traditional approaches, which is spatchel versus tomita versus separation, which is a new one. Thank you.
Thank you. Just one question from the floor, if you have any.
Thanks. So you skipped over the slides. I know it was part of the presentation. So what was the difference in the outcome between the more aggressive surgery versus your separation surgery in terms of your 1 year survival? It's only out to 1 year, your project, yes?
We just grouped the tomita and the separation together, but the survival is almost same. There is no much difference in, you are talking between the surgeries?
Yeah.
Yeah, no, there wasn't much difference, but we saw more comorbidities with tomita rather than separation, because separation is less invasive.
Okay, thank you.
Thank you. Thank you very much.
Thank you.
The next speaker is Yasmin Keith.
So, good morning, everyone. My name is Yasmin Keith. I'm a medical student from St. George's University, and today I'm going to be presenting our research on metastatic spinal cord compression secondary to genitourinary primary cancer, excluding renal and prostate origins. That's my conflict of interest declaration. There's nothing to declare. So, the prognosis of genitourinary cancer varies significantly. However, generally, when it gets to the point of metastatic disease, it has very poor survival. Metastatic spinal cord compression is a rare complication of genitourinary cancer, with surgical management even rarer. As such, there is limited research on these patients, and our paper therefore aimed to assess the key factors which determined whether or not they would have surgical or non-operative management, what factors affected their outcomes, and the relevance of the Takahashi score in these patients. We did a retrospective cohort study of an MDT database from 2017 to 2023. We excluded prostate and renal origins, as these are often more common cancers, so more studied. And then we collected data on key patient characteristics and their outcomes, as well as how they were scored on the Takahashi scoring system. Of this, we were left with only 23 patients from this time frame. The majority of them were male, and the mean age was 73, and you can see the distribution of the ages in Figure 2. We can also see the distribution of their primary cancer types, and we can see that the vast majority were bladder origin, with a few from penile and testicular as well. The Charlson comorbidity score was low across the cohort, and we can see it was slightly lower for the surgical patients, meaning that generally they had fewer comorbidities at presentation. If we look at the outcomes between the surgical and non-operative patients, again, only 4 had surgical management of the 23, so the vast majority were managed non-operatively. And of those who were managed surgically, 100% of them were Frankel score E at presentation, meaning neurologically intact, compared to only 60% for the non-operative patients. Surgical patients had a 0% 30-day mortality, but 100% 1-year mortality, whereas the non-operative patients had a 31.6% 30-day mortality and a 73.3% 1-year mortality. When it comes to looking at their Takahashi scores, again, it was low across the board. Majority scored between 0 and 8 in our cohort, so there wasn't a very wide distribution. However, surgical patients had a mean score of 8, whereas non-operative was lower at 3.15, concordant with their conservative management. Of those who did score between 0 and 8, meaning they would have a predictive prognosis of less than 6 months, the actual survival was 6.52 months, so it does quite closely align with the top end of that range. We didn't have any scoring between 12 and 15, and we only had 2 patients scoring between 9 and 11. They were meant to have a predicted prognosis of between 6 and 12 months, and when we look at the actual survival there, it was only 1 month. And while this does appear disconcordant, it's important to note the very small sample size in this group, meaning that it's difficult to differentiate whether this was a true relationship or just an outlier in this case. So repeating this data with a larger sample size would be beneficial. Overall, we can see that surgical management was typically chosen for patients with few comorbidities and good neurological function, highlighting the importance of careful patient selection. The surgical cohort had a lower 30-day mortality but a higher 1-year mortality, supports the idea that while surgery may provide good short-term outcomes, it doesn't significantly alter the time course of an already difficult disease with poor prognosis already. When looking at the Takahashi score, for the cohort we looked at and the distribution we had, it remains a valuable tool, especially in these patients where there is very limited systemic therapies available for bladder cancer in particular. And we can see those scoring between 0 and 8 were consistent with the predictions. But again, the sample size does limit the generalizability of these findings. However, I do believe they warrants further exploration. So just to sum up, metastatic spinal cord compression is a rare complication of genitourinary cancer, with bladder cancer being the most common primary. The vast majority of our patients did have non-operative management. Surgical management was linked to fewer comorbidities and better neurological status at presentation. Surgical patients had a lower 30-day mortality, however, did not significantly affect the long-term mortality, suggesting limited long-term benefits in stage 4 disease. And we can tell that from our sample, the Takahashi score remains an important predictor of survival. Thank you.
Thanks a lot. Any questions from the floor? I have a question while they're thinking. The 4 patients that underwent surgery, were they done as part of a palliative procedure? Because it is well established even in your own study that there was 100% mortality at 1 year. So yes. What were the indications for the 4 patients, and was it part of a palliative treatment?
I'm not too sure what the kind of rationale was. I do believe it was more of a palliative to kind of improve the short-term outcomes. As you said, it is widely accepted that prognosis remains poor across the board, but yeah, I'm not too sure.
Okay, thank you. Any other questions? Because our own experience has been treating metastatic cord compression or metastatic spinal disease in genitourinary cancers. The urologists are very clear in their concepts of asking us not to touch the patient surgically.
Sure.
So it'll be nice to know why exactly the 4 patients were operated,
yeah.
Although they could make it beyond a year. Thank you. Thanks a lot.
Thank you.
The next speaker is Marzouk Abbas.
Hi, good morning everyone. I'm Marzouk Abbas. I'm a 4th year medical student at St George's, and today I'm going to be talking to you about some of the current concepts in MSCC due to secondary from renal cell carcinoma. So for some background, RCC is a highly vascular malignancy with a significant propensity to metastasize. It has a roughly 70% 1-year survival rate, which drops down to 15% after 5 years in advanced disease, with clear cell accounting for most of the cases. MSCC is a significant complication of the disease, and the typical mainstay of management is a multifaceted approach involving surgery, radiotherapy, and chemotherapy. However, there is the emergence of immune checkpoint inhibitors. Some of the more notable ones are ones like pembrolizumab, targeting things such as PD-1, which kind of may raise the question as to just how relevant surgery may actually still be in managing RCC and MSCC. So the main aim of the study was to actually compare the outcomes of surgical and non-surgical patients. That was the main aim. In a similar vein to Yasmin's talk, we also wanted to have a look at the Takahashi score and to see how relevant that still is. And that might also help us further decide whether we could still use that for clinical decision making and how effective immune checkpoint inhibitors might actually still be. So we looked at the same database of 2,500 patients in the tertiary referral center at St George's. I had a look at 69 patients, or just under 3% of that cohort, and that's some of the demographics that you can see there. It was difficult to fully ascertain the immunotherapy or chemotherapy treatment usage of them, but as you can see, there was a great proportion of that in the non-surgical group, of which there were 27. In terms of their outcomes, what we can see is that there was a 0% 30-day mortality in the surgical group, but this was relatively similar for the at 1 year at roughly 40%, and it was greater at 78% roughly in a surgical group after 5 years. However, one thing we did notice was that the mean survival was potentially considerably lower than we might have expected in both groups, at 8.33 months for the surgical group and 6.97. This was actually significantly greater in the surgical group, at a p-value of under 0.05, which might make us believe that surgery is quite effective, may be effective in acute cases of MSCC. It could also be the case that the patient demographic was just different and that the surgical patients had a better prognosis anyway. In terms of the analysis, going back to the Tokuhashi score, another thing that we saw that might have been a bit surprising was the Tokuhashi scores were quite low in general. The mean Tokuhashi score in the surgical group was significantly higher than that of the non-surgical group, but that still placed them in the lowest category with a mean life expectancy of under 6 months. Again, that might make us question the decision to operate on those patients. Is it the case that the surgery did provide a slight benefit, or was it the case that maybe those patients may not have been the best candidates for surgery? Overall, what we can see for our discussion was that whilst the patient demographics were similar between both groups, the Tokuhashi score still does remain relevant. The 1 in 5 year mortality rates were relatively comparable, and surgery might be effective in the acute cases, but it's quite difficult to say whether there is a significant benefit beyond 24 hours and even over a longer period of time. In terms of the wider use of SACT or systemic therapies, things such as everolimus and other immune checkpoint inhibitors, other immunomodulators, more work would need to be done, as there are papers which show that things such as CTLA-4 and PD-1 inhibitors can induce remission. But again, we probably need a larger cohort and further studies to further elucidate this. In terms of conflicts of interest, there were none for me to declare, and I appreciate the support that we got from the research group at St. George's, and I appreciate their help and input. Those are some references. That's it.
Thank you very much. Very relevant topic to most of us, even in regular practice. Any questions from the floor, please?
Thank you very much. So, I don't quite understand. There's MSCC patients who had a relatively, quite a high Tokuhashi score, but they were treated only with immunotherapy alone instead of having surgery. Is that what happened? So you've got two different groups, some people who've got cord compression, but not being treated with surgery.
So we had the surgical and non-surgical groups. In both cases, in the non-surgical group, the mean Tokuhashi score was 6.6, which was, you could say, puts them in the lowest category of under 6 months. So what we found was that the Tokuhashi score was actually relatively low in both groups, just it was marginally higher in the surgical group.
Yeah, but my point is that the patients had MSCC. These
Yes.
are all patients with MSCC.
Yes, all had MSCC.
And then you didn't present the neurological outcomes for them, just survival. Did you have that, or you don't have the? Because the reason why I mention it is just, if you can walk and go to the toilet in your last 6 months of life, it's on average preferable to not being able to do that, even if you have a similar life survival, So.
Yeah, we did. There was some data on the ECOG performance data and on the Frankel score. I didn't see any significant changes. That's why I didn't gloss over it.
All right.
Between both groups, yeah.
Both groups are the same.
Yeah.
Thanks.
I think what Mr. Anwar is trying to ask you is, there's usually an inherent bias in the decision making as to which of the patients we select for surgery and who are the patients we do not select for surgery as well. Any other questions on the floor? And given your database and given the advancements in the immunotherapy and the targeted therapy we have, I was surprised to see that there was a mention of chemotherapy. I thought we moved away from chemotherapy. Was there any subgroups that were selected for chemotherapy or that did better?
In the group that we saw, that wasn't anything that I particularly noticed. It was mainly the SACT in comparison, but some of them did have chemotherapy, which, like you said, was surprising. But I don't have any specific data to see whether there was a subgroup which.
Okay. And have you or your unit noticed any trends in differential when it comes to vascularity once your patient is undergoing immunotherapy or targeted therapy? Even if they required surgery on a later date, was the vascularity less of a problem when they required it once they've had immunotherapy? Do you have any data on that? It'll be quite interesting for us to look into these data, because as surgeons we worry about bleeding, we worry about the bulk of vascularity that we encounter.
Yeah, I didn't get to look into any of the trends, but this is something that I think we should look for in
Thank you.
detail.
Thanks a lot. Any other questions? Thanks a lot. Our next speaker is Sofia Mavili. Thank you.
Good morning, everybody. I'm Sofia Mavili. I also am a fourth-year medical student from St. George's University. Today's presentation is on lung metastatic spinal cord compression, similar to my colleagues from St. George's who've just presented, but looking primarily at lung cancer as a primary site. So just a little bit of background information. Current UK data shows that stage 1 one-year survival is approximately at 90% for lung cancer primaries, whereas stage 4 is around 15% in males and 19% in females. Since 2021, we have seen an improvement in the therapy provided to the lung cancer patients, particularly in SACT, and also immunotherapies and KRAS inhibitors. And these are drastically changing the prognosis of lung cancer, which historically has had a very poor prognosis. So the study objectives, we mainly looked at the surgical and non-surgical operative outcomes with regards to their survival. We also evaluated the treatment outcomes, which percentage had immunotherapy in which group and which did not, but also taking a look at the Tokuhashi scoring system in determining the prognosis within these patients. The methodology, we had a database of 2,500 patients. Approximately 418 metastatic spinal cord patients were identified within this basis. And of the lung cancer patients, we had approximately 122. 48 of those were surgical patients and 74 were non-surgical. What's important to note here for the non-surgical patients is not all non-surgical patients were in the non-surgical group because they were palliatively looked after. Percentage of these patients also had complications from COVID, sepsis, and high comorbidities, and unfortunately passed away before the MDT decision was made. Looking at our patient demographics, we can see there's comparable statistics of male to female ratios between both surgical and non-surgical groups. Whereas looking at the number of metastases, the surgical cohort had about 6% of more than 3 metastases in the spinal cord, whereas non-surgical patients had a more extensive disease with more than 3 metastases in the spinal cord. 38% of surgical patients were offered immunotherapy, whereas 29% of the non-surgical cohort were eligible for immunotherapy treatment. Also taking a look at the Bilski score, and on average, surgical patients scored about 3 on the Bilski score, whereas the non-surgical patients were at a 1, so had a higher degree of spinal cord compression. The average Frankel score pre-MDT was lower in the surgical cohort. Important to note that this Frankel score is from the Tokuhashi scoring system, so the surgical cohort would have scored with more motor function deficits than the non-surgical cohort. I can appreciate that this graph looks slightly confusing. The Tokuhashi scoring system, so looking at the non-surgical cohort, we had roughly 7 patients in the 9 to 11 range, 9 from the non-surgical cohort in the 9 to 11 range, 65 from the non-surgical scored 0 to 8, whereas 41 from the surgical cohort scored 0 to 8. It's again important to note that none of these patients scored above 10 on the Takahashi scoring system, so all patients were predicted a maximum of 12 months survival. We used the Frankel scores to compare pre-surgical and post-surgically for our surgical cohort, and we can see that 17 patients were reported to have an improvement in function that was relatively significant to their quality of life. But breaking it down, we can see 32 had an overall improvement in function, 12 reported no change, and 4 reported a decrease in their original function. The mean survival between two groups was 20.5 months in the surgical cohort and approximately 8.5 for the non-surgical group. Now, this was a mean average through both the cohorts. Non-surgical patients scored, had a mortality, of 68% at 12 months, who were scoring 0 to 8 points. So for 0 to 8 on the Takahashi score, we predict that they'll be living less than 6 months. But there was only a 68% mortality at 12, so patients were living considerably longer than predicted. Whereas in the 9 to 11, we had a mortality of 14% at 12 months. Now, these results are quite similar to the non-surgical group. So those patients in the non-surgical group scoring 0 to 8 had a 52% mortality at 12 months, and patients scoring 9 to 11 had a mortality of 13% at 12 months. When we look at the percentage accuracy of the Takahashi scoring system for these cohorts, we can see for the surgical patients it was 62% accurate, whereas for the non-surgical patients it was 53%. So for in our discussion, surgical patients had a higher mean survival months overall, but one-year mortality rates between the cohorts were comparable. 66% of our surgical patients were reported to have an improvement in their motor function and their symptoms following their surgery compared to their baseline. However, as mentioned in the methodology, there were patients in the non-surgical cohort who weren't operated on, not due to the degree of their cancer, but for unrelated causes. The Takahashi scoring system scores all lung cancer patients 0 in the domain of their primary cancer site. And with the era of our checkpoint inhibitors and immunotherapy options, we are seeing that these patients are living longer without surgical input. So whether that 0 figure can actually accurately reflect on their survival is in question, particularly when we're deciding based on the Takahashi scoring system whether these patients may or may not be operated in regards to their prognosis. It still does remain a useful tool in helping us. However, with this advancement of our immunotherapy and systemic anti-cancer therapy, it's important to keep the NOMS-guided decisions and keep collaborating with oncologists and see whether our patients are available for checkpoint inhibitors when then deciding whether they are suitable for surgery or not. Our data shows that we are surpassing survival by 50%, and this is a greater number compared to the UK national statistical data. Also from our data, we can see that even patients scoring low on the Takahashi scoring system are benefiting from a more aggressive approach to treating their metastatic spinal cord compression. Conflict of interest, there are none to declare for this presentation. Thank you very much.
Thanks a lot. Any questions from the floor, please?
Thank you very much. The long and short of it is, what I want to know is who do I want to operate on, who do I not? And it sounds like the Takahashi is a fairly reasonable indicator. But what I was trying to work out was that you had 48% of the surgical patients, 48 surgical patients, 17 of them improved in function, 16 were no change or got worse.
I realise from the presentation, sorry to interrupt you, that 17 hasn't been updated. The correct number of patients who had an improvement was on the bar chart, which was about 32 patients.
Okay. So, just over, actually that's about 2/3 then, actually improved with the surgery.
Yes.
Brilliant, thank you.
Also, sorry, just to elaborate on that point, some patients, obviously looking at the Frankel score, we're trying to reduce the subjectivity. So although some patients may have had a minor improvement in their motor function, that wouldn't have warranted them to move up in the Frankel score.
Thank you.
Thank you very much. Great presentation. So the Bilski score for the non-surgical patients, the average was 1, I think, and for the surgical patients was 3. So a Bilski of 1, probably that patient doesn't have spinal cord compression. So I think that's one of the problems I see a lot in the literature, that people are being reported, surgical versus non-surgical and so on and so forth, with different cohorts of patients, right? On one side, you've got patients who've got more than 3 Mets, who've got a Bilski score of 1 and do not have cord compression. And on the other, you've got people probably with cord compression with less than 3 Mets. You see what I mean? So they're two totally different groups. So to compare them doesn't tell you, what do you think that comparison tells you, apart from just that the people with more Mets are living for less time?
I agree, yes.
Thank you.
Thanks a lot. Thank you. I think we'll move on to our next session, but just please do make sure that you get a copy of your column and cord journal. It's kept outside. Thank you.
Good morning, everybody. I'd like to start the next session. My name's Valerie Sparks from Cardiff University. I'm moderating part of this session. So the first part of this session is going to be hosted by Christine Lemaitre, the Sheffield team actually, Christine Lemaitre, Lee Breakwell and Ashley Cole, all from over the Pennines. So I'm going to leave you in their capable hands, but can I just remind people, because the session's been recorded, any questions that needs to be posed need to use the microphone. Thank you very much.
Thank you, Valerie, and good morning, everybody. We decided that Christine would do a nice scientific talk with some clever stuff in it, and then the three of us would try and explain what our view of collaboration is from our personal perspective. We've worked very closely together for a number of years now, and certainly seen the fruits of that labour. And it's great to be able to be on stage with Christine and share that with you. So the plan is to have a little chat about the three of our perspectives on collaboration, what that means to us, how it's worked for us. Christine's then going to give her talk, and then we'll have a time for chat about one, the specific talk, and then two, about collaboration, if people are interested. So the question really is what is collaboration? And obviously there's different concepts, and depending on where you're coming from. So the definition is essentially fairly open, that the situation whereby 2 or more people working together to create something or to achieve something. It's actually quite an old word, but perhaps not as old as you'd think. It's felt that it perhaps comes from French, which upset me a little when I found that, but there you go. The first appearance in the English language was in 1860 in a novelist's book, which is quite interesting thought. So when you think about collaborations, things pop into your mind, and obviously some are perhaps unexpected but can be absolutely amazing. May not be everybody's cup of tea, but this is perhaps an example of a collaboration that one wouldn't have thought would be ideal, perhaps wouldn't have thought would work, but is perhaps one of the most famous Christmas songs going. On the other hand, there are collaborations where you could probably predict failure and probably wish it had never happened. And as a fellow Midlander, it's upset me that Aussie had anything to do with Miss Piggy, and you don't see Miss Piggy at international meetings too often, do you? So that was perhaps a predictable one non-hit wonder. So in terms of collaboration, we've been working together the three of us, with our colleagues back in Sheffield for many years now. And it's a collaboration between the universities in Sheffield and the medical school where Christine is now based, and our clinical work at the hospitals. And we started out very simply with some clinical input to Christine's studies, trying to explain our perception of back pain and leg pain with regards to disc clinical relevance. And then we started simply just collecting disc samples. So when we do a microdiscectomy, we collect some disc and we send it in a pot to the lab, and Christine and her team have done more and more work, more and more complex work, and it's sort of snowballed from there. So there were several talks yesterday on injectables and hydrogels, and our team have been involved in some of the basic research on that. And so it's coming to the stage where we may now start doing some interventions as the surgeons, such as injections, such as injectables. And we've presented and published a few papers on that. So this is just a sample of the papers that we've achieved as a team. And it's interesting, as the orthopod in the group, I don't even understand the title of many of my publications, which probably says something about collaboration. But you can see that the number of citations on some of the papers is really quite high. So we've made an impact in this world, in this area. And I'm really proud of that, and it's great, and it sort of adds value to my practice. But it doesn't always work. There have been some studies that have been a bit more difficult. We were involved in the spine microbiome study looking at the effect of infection in the disc. And this was launched whereby we would be collecting samples specifically for this collaboration amongst other universities, not just Sheffield. And it came out at the time of COVID. So we did about 3 microdiscectomies in 2 years at the Trust because of COVID and the effects of that, and then the recovery with myelopath patients. And so that was a very difficult study to function. And so it doesn't always work despite best efforts. On the back of that, because we've had a close collaboration with Christine, we've then reached out and branched out in other university departments. And so we're very lucky in Sheffield. We have Insignio, which is the in silico medicine engineering department. And they came to us that you don't realise these things unless you have a conversation. So they have an FEA model of the lumbar spine. And we found out, and then we've worked on that. So we've looked at tumour modelling and vertebroplasty, and we've published and presented a few little papers at the start of this collaboration, looking at screws and cross connectors in the lumbar spine for tumours. And now this is branching out into international studies looking at metastatic disease and vertebroplasty, and the Sheffield dot, the correct side of the Pennines, on the UK there versus the rest of Europe. So from my personal point of view, collaboration is really useful. It adds variety to my practice. Those of us who are spinal surgeons, you do your job. It's nice to have something different to think about, have different people to talk to. You meet lots of different clever people who have a different perspective on what you thought you understood. And that's been really challenging but very helpful, I've always found. It's opened up contacts with other academic communities, and the clinicians ask scientists, what do you think about this? And of course, the reverse question is equally, if not more important often, is why do you do what you do? Can we answer that question for you? And hopefully one day this will translate to real tangible effects for patients with back pain and degenerative spine disease. Thank you very much.
Thanks, Lee. In the audience, have we... Could you just put your hand up if you're a physio by trade? And surgeons? And basic scientists? Okay. So I think I agree with everything that Lee said, and collaboration for me has been great. Done a lot of collaborative research, and some of that can be multi-centre stuff, so collaborating with the same profession in different centres. And I think there's important collaborations with the physio groups as well, particularly the physio groups doing primary care, triage and treat. There's a lot of things that we don't know about natural history of spinal problems. And I think that's something that spinal surgeons who maybe don't have such an interest in basic science can collaborate with their physio colleagues and do some proper multi-centre research. And so, for me, sorry, I wish I put my glasses on now. For me, collaboration is really just an extension, thank you, it's really just an extension of my everyday collaboration that we collaborate every day. We talk to different people, whether it be nurses on the ward, medical students, junior doctors, we're always collaborating. And this is just an extension of normal everyday life for me. And I've been doing spinal surgery for many, many years. And after a while, it gets a little bit dull, or it does for me. I need different things to keep me excited and get me out of bed on a morning. And so that's what collaboration really does for me on the research side. It gives me something different to do on a day. And of course, you know, your collaboration, what we're going to talk about today is a bit of basic science collaboration. In this term, biology, as Lee mentioned, we also have collaboration with our biomechanical colleagues, and I'm just starting some collaboration on the computing side, the artificial intelligence side. Many of you might have been involved in collaborative research thinking about implant design. And I think if we want to advance spinal practice in the next 20 years, it all comes from this collaborative research, right? You look at what we're doing now in spinal surgery compared to where we were 20 years ago, and it's all come out of collaborative research. So the clinical input is vital to bridge this gap between research and practice. Christine knows all these clever components of the disc and how to run experiments on discs, but it's the practical applications of this. And I think the other thing is, for the surgeons in the room, we've all been blessed with our careers and what we do, but there's a little bit of giving back. You know, we can't go through life just taking, and this is a little bit of give back. So get involved in some research and give something back, and it is great fun. You will be rewarded for it. And so when Christine and I sat down many years ago, and we sort of thought, well, where is the clinical applications to what she's doing? And one of the big problems when you're starting in developing sort of hydrogels to reconstitute the disc is, when should you use it? Has anybody thought of that? So we all know that if we MRI everybody in this room, we're all going to have disc degeneration. So do we all need injectables in our discs to stop them degenerating further and maybe regenerate them? Which patients should we use it on? And then we thought about, can we inject hydrogels into a disc when we do a microdiscectomy to try and sort of glue it all back together again, regenerate it a little bit, and prevent recurrences? We all know that recurrences are 10% of our discectomy practice. And can we tweak the hydrogels a little bit to form bone? So imagine that you're doing an interbody fusion, but instead of putting a cage in, you basically just pass a vertebroplasty type needle down the pedicle, across the disc into the bone above, and then inject a hydrogel that turns to bone. And so it's just that kind of thing. You can think about little ways of using new products. And why does Staph aureus, when we see Staph aureus infections, they always fuse, don't they? You know, 6 months later, what is it that Staph aureus produces that makes things fuse? And can Christine use things like that to make bone for the scenario above? So there's lots of things where you can use your grey cells and just use your clinical experience to help the basic scientists make something that will advance our practice. And I've not mentioned, other than at the start, all the collaborative stuff that we should be doing with the physios, but I don't want people to forget about that. I think whilst it's not basic science research, it's still collaborative research. And some people may like that kind of collaborative research, other people may like the basic science collaborative research. It's horses for courses, isn't it? So those are just my few thoughts on collaborative research, but get involved. It is good fun.
Thanks, Lee and Ashley. So before I go into my actual presentation, so I wanted to add kind of my comments as well to collaboration. I didn't do any slides because I ran out of time, but I think, you know, from a fundamental scientist perspective, engaging and collaborating with clinicians, with patients, you know, and actually getting that conversation on industry as well, that is so important, because otherwise, if we develop things as a fundamental cell biologist, often you kind of think, oh, that's interesting, and you do it purely because you're interested in understanding how the disease works and everything. But actually, if you develop a better understanding, but you never get to developing therapies or things that can actually have an impact on patients, well, it's kind of what's the point as well, you know. So we really need to make sure that we're having those early conversations with the clinical partners, with patients, to understand what are those areas of unmet need, and then trying to use our strategies to try and develop kind of strategies to target those unmet needs. So Lee and Ashley kind of came up with a number of the really good examples of things that we've worked on, you know, and obviously one of the key things as well is accessing human samples. So all of my research is dependent on human tissue samples, because if we look at human tissue samples, that's actually where the disease is happening. And that's the closest approximation to actually looking within a person as well. So it's really important to kind of have those links and collaborations. And then also across kind of disciplines as well. I'm a very interdisciplinary scientist, so I work together with engineers, material scientists, biomaterials, statisticians. So all of those different skills and disciplines all come together to be able to develop the research projects and things that we do as well. So before we go into the science, we wanted to open up the floor, first of all, to conversations around collaborations and also experiences that other people have had, you know, around collaboration. So if you've got things that you want to add to kind of this conversation, please do come forward to the microphones and things. We've got a bit of time, first of all, to kind of discuss the benefits of collaboration. Or also if you've got, you know, you're trying to set up a collaboration, you're struggling a little bit, come forward, you know, we can answer questions on that. So please do come on up.
I'm going to ask the first question. Do you think the drive, we saw a really lovely lecture, the first lecture of the meeting, talking about AI and how it's sort of really rapidly developing. Do you think there's a jeopardy here with AI being detrimental to collaboration? Or do you think it's going to be advantageous? I'll ask any of the panel for their views on that.
Yeah, I'm hoping that AI is just going to help us. It's just going to make life, it certainly makes my life a little bit simpler now. Some of the things that I mean, I'm just starting to explore AI, but I think there's a whole world of things that we could do, particularly maybe on the physio side with AI. I think there's, you know, using AI to help us out with our triage and treat in lumbar degenerative problems, cervical and lumbar degenerative problems, is certainly a way forward. So I hope it doesn't stifle collaboration. And I'd be interested to hear from some of the physios in the audience around whether they find collaboration with their surgical colleagues on a research side is working or not working. I've seen some surgeons, I saw some of the surgeons on the physio research papers, and some of the papers are really, really good, high quality papers. And the surgical teams I recognised as people who've retired. Am I being unfair? Partial retirement. Yeah. So, I mean, do any of the surgeons get involved does any of the surgeons in the room get involved in basic science or physiotherapy or other collaborative type research? One?
Put your hands
two,
up.
Three. A few? Yeah. Yeah, good. Okay, so there are a few.
Sorry, could you come to the microphone,
Yeah.
Rav? Sorry.
I think it's easier in the earlier phases of training to be involved in basic science. So if you do an intercalated BMSI or you do an ACF, that is doable because you have protected time. But certainly as a trainee, as a registrar, when you're doing a rotation for 6 months and then going another speciality, that becomes a little bit difficult unless you're taking time out program. I'm guessing that changes in consultant life, but certainly as a trainee for those 10 or 12 years from undergrad to CCT, or 20 years actually, it's difficult, but easier earlier on, I think.
I mean, I guess even if you're not going to do the research yourself, you know, and obviously if you're doing the ACFs or integrated BMSIs, you can actually get involved with the research. Then even just having those conversations with researchers, you know, so I quite often, well, I wouldn't say quite often anymore, but I have, you know, come along to kind of Wednesday morning meetings, you know, and have those wider conversations with the surgical team. And just having that discussion, that's where all the ideas come up, you know, so it doesn't actually take that much commitment time, I would say, to have those wider conversations. And even just kind of a one-liner or a quick conversation can really spark a whole kind of, you know, pathway of research. And then you can obviously, you know, keep going and getting involved, you know, put grants in and things. But actually, I mean, the kind of work involved probably isn't too much, I would hope, you know, in terms of actually how much time you need to dedicate as well.
Good morning. I think this is fascinating. I'm a physio in the south. I think the biggest challenge is that a lot of physios are based in primary care and a lot of our surgeons are obviously in secondary care. And I think therefore bridging the gap and getting teams in the same room or online and sitting down and discussing it is our biggest barrier to collaborative work from physio to surgeon. That's just a statement, really.
I would agree entirely. And what I would say is in Sheffield, we've been very lucky since we set up the MSK pathway many years ago now. We have a virtual MDT once a month. And so one of us on a rotation spends typically only about half an hour to an hour. And the physio, one of the physios brings the 10 or 12 cases from that month that have been a bit uncertain. So the MRI is either equivocal or the patient's a bit odd symptom-wise, it doesn't quite fit. So the barn door, nothing to do, get sent to pain management or physio. Obvious surgical cases that they're now happy to deal with come straight to us. And then there's the grey area. And we both find it really useful because we can educate the physios to an MRI in more detail. They can educate us to how their process is working currently. And that dialogue, it's just an hour maybe once a month, is invaluable because all the physios know us because they work in a different building. You're absolutely right.
So we do have that set up as well, but I think it's going that next step beyond to actually start after the meeting of the clinical 10 patients that are there in front of you actually saying, let's hang on and have an extra half an hour to this meeting and talk about some collaborative work to happen. It's also funding, so different trusts have got different ideas about what they're happy. So primary care, do they want to fund something that is to do with secondary care and vice versa? So anyway, that's my can of worm, sorry.
I mean, I'd say to the surgeons in the audience that, you know, this sort of collaborative work you do in your own time, you've got absolutely no chance of getting funding for it. Unless you're actually doing a proper project that comes out of that collaboration that you can cost into a real grant. And then you might get some time, but you do it for the love of it.
Yeah, and I think to start with, it always takes that extra level of work to put in to set up the collaborations, but you know, actually things like, you know, so NIHR, MRC versus arthritis, they're very much looking now for much more collaborative teams within projects, so then you do have a chance of actually buying, you know, some of your time for research and things as well in the future, but obviously it's all dependent on grants and things. Sorry.
Hi, I'm very lucky working with these guys. That's collaboration and it works really well. But I think what's helped with the primary care setting and as well as the MDTs, we've got the links now. My colleague sort of heads up the research protocol, so there's a pathway you can go on to start where if you know develop a pathway so that you know where to start, so you can get an idea, that's mooted, then it can go through channels, go to the appropriate people, surgeons. So because our problem in the past has been, where do you start, like that lady just said, but if you can get pathway on identifying a research pathway with it.
Okay, we probably need to move on to...
I'm just going to make one last comment, yes. And as a moderator, I take the liberty. I think I just want to give an example in Cardiff University. I think we've got a really good relationship with surgeons, Mr. Huja and other team working within with physiotherapists, but also within engineering. And I think it's the enthusiasm of all the colleagues working together. And as I agree, Christine, it sometimes takes a lot of kickstart to get things moving. But once you've got those relationships, they're really valuable. And I think working collaboratively, that's really coming to the fore now with funding. And for example, Versus Arthritis, they've now got these consortium grants because we really realise that we can't answer the big questions, be it disc degeneration or osteoarthritis, with singular projects, single-minded. So this consortium funding that's coming, certainly there's 2 calls in this next year, they'd be really key grants to get, where you get surgeons, physiotherapists, biomechanists, the whole psychologists, I don't want to miss anybody out, but the whole program. Sorry, fundamental scientists. That whole collaborative working together to answer those really big questions, which in a single grant are quite difficult. So thank you very much.
Thank you. So that concludes this bit of the conversation, but we will have time, hopefully, at the end, if you've got any other comments on collaboration or anything. Do you want me to just introduce myself, Val? Yeah, so I'm now going to go into kind of my demonstration, really, of some of the work that we've been doing through the collaboration, with Ashley and Lee and the broader team as well. So I'm Kristen Lemaitre. I'm based at Sheffield University, across the Pennines and things, and I co-lead the Joint and Disc Research Group within the medical school there. So just to say, so conflicts of interest, but also actually this is an example of further collaboration as well. So the work that I've done has led to patents within the hydrogel systems, which has now been licensed back to a company, Orthoson, but then also I have links and consultations with other companies, so Parcera in America and Paradigm Spine as well, where they've kind of come to me for expertise within their areas as well, and I've received funding from Flexion and Parcera. So why am I interested in low back pain? So we all know in here that low back pain is the biggest cause of disability worldwide, and it affects millions of people, but the key thing is that disability and the pain that it generates doesn't just cause pain, it actually links in to kind of decreases in the physical ability, the psychological ability, and socially as well. My mum had back pain when she was very young, and she had to kind of give up work a lot earlier than she would have wanted to. I didn't have back pain when I started researching it, but I do now. And I've kind of got, real awareness. Actually did the surgery on my spine as well. So, I've got a real awareness of what it feels like. And it's not in your head, and it is something, there is something that triggers it. And then that then triggers a lot of other things. So what is it that actually causes it? And quite frankly, it's not good enough that we have 85% of people with back pain that's just classed as non-specific, and a lot of the time they're left with pure symptomatic treatments. So we want to have this better understanding of what causes back pain, so we can now lead to new therapies, hopefully in the future, so that 85% of people, at least some of them, actually have some better options for treatment. So disc degeneration is associated with back pain in about 40% of cases of back pain, and this is just an example. I don't really need to talk about this. You all know what discs look like and the degeneration. And we know that disc degeneration increases with aging, and that's one of the big arguments. Well, it's just consequence of aging. What's the problem? It's just normal. It's not a disease. But it's actually in these younger individuals, 55 years and under, where the association with disc degeneration and back pain is much stronger. And it's in these individuals who are the working age groups who are impacted the most by the impacts of back pain. So what is disc degeneration? So the discs are in your spine and they allow you to move and flex. And this really good image from a number of years ago from Broddock and Adams, shows really clearly that the intervertebral disc in a normal disc, and I don't know if the laser works or not, but in the top region, you can see clearly this central gelatinous nucleus pulposus. So that's rich in proteoglycans, and it provides the compressive properties of the disc. And this is constrained on the outside by a very highly ordered annulus fibrosus, which is layer upon layer of collagen fibers. Now, during degeneration, the cells within the disc change their behavior and start to change the matrix that's present within the disc. They start to degrade it, and it becomes much more fibrotic. So you can see as it goes down the stages of degeneration, that gelatinous nucleus pulposus is lost, it's become more fibrous, and now you're losing the normal biomechanical properties of the disc until eventually it's just completely knackered at the end with severe degeneration, and it can actually cause automatic fusion. So what we're looking at is in this low grade to moderate degeneration, can we actually look at trying to halt the cellular processes that are triggering degeneration and then actually reverse it and regenerate? And in severe degeneration, where most likely it's better just to hurry along the process and fuse it quicker, can we actually increase that more rapidly? I'm not going to talk too much about the fusion aspects today, but we do have strategies which actually came directly from those conversations that Ashley was talking about in terms of can we use our gel systems to induce fusion instead. So we do have a bone gel system where you could potentially turn the disc into bone in those later stages as well. So if we look at the disc is the largest avascular tissues in all of your body. So that means the nutrient supply within the disc is really low. It generates a low pH, it has low oxygen levels, low glucose. So it's a really hostile environment for cells, but the cells within the disc are used to that. So they've adapted to this low glucose environment and the lower pH. And they're quite happy in there, so in a normal disc, they're producing the correct matrix, they have a normal homeostasis and regulate the kind of degradation enzymes and everything, and it all stays fairly okay. Now, during degeneration, you have this increase in degradation enzymes and the change in matrix that's produced, and what that leads to is cracks and fissures that can form within the outer annulus fibrosus or within the end plate, and that can lead to blood vessel and nerve ingrowth that can then cause the disc to become painful in itself. In addition, the degradation of that annulus fibrosus can lead to disc herniation, which then the disc will squeeze out and press on local nerve roots, causing sciatic pain, etc. And one of the other features that's very commonly associated with disc degeneration is modic change. And modic change is where you have the vertebral bone marrow lesions, which are associated with disc degeneration. And in those individuals with modic change, they have a much greater intensity of pain, and also the durations of the pain is longer as well. So that modic change always used to be just thought because it was mechanical stress. So as the disc degenerates, that puts more stress on the bones, which causes the bones to basically cause osteolysis. But it's now thought that there's two other potential etiologies. One of these is autoimmune. So we know that the disc doesn't contain any immune cells, but actually factors produced within the disc, which are not normally in contact with the immune system. Once you've got these cracks and fissures and blood vessels coming in, the disc is now in contact with the immune system in the adjacent bone, and that could trigger an immune response within the bone and cause activation of immune cells and osteolysis. And there's also the proposal that there's also an infectious etiology where a low-grade bacterial infection can actually drive this osteolysis within the modic change. So what I'm looking at is trying to understand the cellular process of degeneration, it's associated with modic change, and then how we can treat this going forward. So just to explain a little bit more about some of the components of the disc, because this will come up later. So within the intervertebral disc, as I say, you've got this annulus fibrosus, and the main component of the annulus fibrosus is collagen. So you have this concentric layers of collagens, and you can just about make out the cells in there that are slightly darker blue, little substances. If I had a laser, I could point to it, but I don't. And this is the nucleus pulposus. So you can see the cells, which are these little clusters, because this is actually a degenerate disc. they're embedded in this really rich matrix. So there's very low numbers of cells within the disc tissue because there's not that much blood supply and nutrients. So they live at low levels of cell numbers. And these cells in the nucleus produce two main proteins, so aggrecan, and that's what forms holds onto all the water in the disc, so that's really needed for that hydration, and also type 2 collagen, which forms basically like a network that holds the whole structure together. So we know that during disc degeneration, you get an increase in a number of enzymes within the disc. So this is a method called immunohistochemistry, where we can look for specific proteins within the disc. If the protein's there, it's brown. If it's not there, you just have your cell staining, which is the purple. So MMP1 and ADAMTS4 are two key enzymes that disc cells produce, but they increase that production during degeneration, and they will then degrade the rest of the matrix. And we know that within disc degeneration, there is an interplay of genetics, abnormal loading, which can change the response to cells within the disc. So in a non-degenerate or normal disc, when you apply normal load, so walking around, running, etc., that normal load level triggers those cells to produce their normal matrix. So you'll get an increase in aggrecan, collagen type 2, for example. But as the disc degrades, either an abnormal load can actually induce changes in the cell's behavior. So if you overload the disc, then you can trigger more catabolism, which is where you get this enzyme production. Or even more normal loads, once the disc is degraded, the cells now can't respond to those normal loads the same, so now those normal loads can actually cause more damage to the disc as well. Environmental factors such as lifestyle and also potential infection as well can also play a role. So one of the things that's very contentious within kind of the disc field is whether there are bacteria present within the disc, and this is one of the things we've been more recently looking at as well. So a lot of the evidence around bacteria originally came from surgical samples, and many of these were herniated tissues. So the argument often with the herniated tissues is, well, it's been exposed to the rest of the environment. Those bacteria weren't there when they were in the middle of the disc. It's only come up once it's been herniated. And also a lot of the methods that were used were looking specifically for individual bacteria, so what we call candidate approaches, rather than screening for kind of any bacteria present. And a lot use things like microbiological culture, which has the big disadvantage that certain bacteria just won't grow if you take them outside of the body. You know, they're used to growing, if they are in the disc, in a low oxygen, in low nutrient supply. If you take them out and put them in a rich agar with normally oxygen, well, they won't grow, they'll die. And then there's a newer technology known as 16S RNA sequencing, which is where you extract the DNA from that tissue, and then you can look for bacterial signatures within that tissue to see whether there's bacteria present. But the big problem with that is that's so easy to contaminate with either the environmental signatures or from the outside of the tissue during the surgery. It's very easy to get those contaminations. But there's been quite a lot of work out there, and actually this is a systematic review that demonstrates there is evidence for an increase of bacteria with modic change particularly. And this really interesting study from Stefan Dudley's group in Switzerland showed that if they look at the number of C. acne copies, then actually a lot of the discs, even the non-degenerate discs, also had C. acne present. But in those discs that were associated to modic change, shown on the bottom, in some of those discs, there was very high copy numbers of C. acnes. So there seems to be kind of a high and a low population in those with modic change, but just a lower population with those without modic change. And there's been some great work by Rajasakaran from India and also Stefan Dudley in Switzerland, which has looked at the kind of the 16S sequencing and shown with that data, just bearing in mind it might be contamination, but we need to look at that, that actually it looks like there are bacteria present even in non-degenerate discs, and that you get this dysbiosis during degeneration, or that the dysbiosis is causing degeneration, we don't know. So one of the things we wanted to look at, because we have now about 700 discs, thanks to the surgeons over the last 15 or so years, we've actually got this very large bank that we can go back to. When Ashley and Leah collecting the samples, they actually put on the form whether or not the annulus fibrosus was still intact or whether or not that disc is sequestered or extruded. And that's really useful because we can then go back and say whether or not it's likely that disc was still contained. Now, obviously, bear in mind there may be small cracks and fissures that you can't see, and there could be end plate cracks and things as well, but not likely in every sample. And then we use that method called immunohistochemistry to identify exactly where the proteins are associated to those bacteria, so we're ruling out the chance of contamination. We looked across 95 different human discs and included within their cadaveric discs as well as the surgical samples. And what we saw, looking at 2 of the bacteria, which were selected more from the 16S analysis as the most kind of identified within the disc, we looked at C. acnes and Staph aureus. And really interestingly, C. acnes was found in every single disc we looked at, all 95. But what we never saw was we never saw biofilms. So what we actually see is the bacteria is internalized by the disc cells, and then it's either staying alive within those disc cells or it's died. But because we see it in actually quite a lot of the disc cells, we suspect it is still alive. Whereas Staph aureus was found in a fewer number of discs and in much lower levels. So if we quantify this, so purple are female and green are male, so also we see this gender difference, particularly for Staph aureus. So in Staph aureus, there's very few males with Staph aureus present within their discs, but actually the females there's a lot more, which is interesting. We need to look at that more. But with C. acnes, it's across both genders, and there doesn't seem to be an association with this initial antibody with age, with degeneration grade, or with modic change in terms of significant differences. But one of the key things is there's lots of different types of C. acnes, so what we're now looking at is there differences with specific phylotypes of C. acnes to see is there differences between a more pathogenic strain, for example, than a more commensal strain. So we then wanted to see, well, do any of these bacteria correlate with these catabolic factors within the disc? So looking at a cytokine, interleukin-1, the 2 enzymes, MMP3 and ADAMTS4, and then gastronerin D, which is a marker of pyroptosis, which is associated with disc degeneration. We can see when looking at correlations, we do get correlation of C. acnes, but not Staph aureus, with some of these factors. So how do disc cells actually recognize bacteria? So I'm going to show a very complicated diagram, but don't worry, I won't go through it. So basically, there's lots of receptors on many cell types that can recognize bacteria. So toll-like receptors, there's internal receptors called NOD2 and NLRP3, and these all can recognize bacterial cell components. But most of these have been characterized within immune cells, not in disc cells. And as I say, discs don't have immune cells in them. But what disc cells seem to do is take on a lot of these immune cell functions. So it's known, for example, that disc cells do express toll-like receptors, and actually if you treat disc cells with toll-like receptor agonists, which activate them, they can increase the enzyme production, etc. But no one had looked before whether disc cells also express things like the NOD2 expression. So we looked again within our disc samples, do they express NOD2? And indeed they do. And the levels of NOD2, interestingly, correlate with the levels of C. acnes within these discs as well. So you can see the correlation graphs. So what could C. acnes be doing within the disc? So it's known from previous in vitro and in vivo studies that if you treat discs with high concentrations of C. acnes, that can induce degeneration. But because when we looked within the disc, we never saw biofilms, that actually suggests that we're looking at low-grade levels of bacteria because it's at a level where the disc cells can internalize them. We're not getting kind of an outgrowth of bacteria within the disc tissue. So we wanted to look at more realistic levels of those bacteria, what could be occurring. So bacteria have kind of different membranes. You've got gram-positive and gram-negative bacteria. Gram-positive, which C. acnes and Staph aureus are, have peptidoglycans on their membrane, and other gram-negative, such as E. coli, have LPS. So what we did was take disc cells and treat them either with LPS or peptidoglycan, or co-treat them with low concentrations of C. acnes and Staph aureus to understand what they could be doing. The cells can internalize the bacteria, so you can see these are bacteria we've labeled with green, and the disc cells can take them up, so they do go into the disc cells just like we see with the in vivo tissues. And when you treat with peptidoglycan, so the stronger the blue, the higher the expression level of these different cytokines. You can see when you treat with peptidoglycan, at quite a high dose, you get this induction of lots of these cytokines. And we also see these intracellular signaling pathways, which are the ways cells kind of turn on these catabolic factors, are also increased with the peptidoglycan treatment. But interestingly, they were not increased by these low doses of bacteria, and actually it looked like some of them were decreased. So for example, junk actually looks like it's going down with your Staph aureus treatment. So looking at some of these cytokines in a bit more detail, we can actually see that some are decreased by this low dose treatment of Staph aureus. So it could actually be that these bacteria are actually protective and similar to a lot of the tissues in your body are actually beneficial. So just by treating with antibiotics might not be a good thing because there might actually be a normal microbiome of the disc. So this is something we want to look at in more detail. And within other species as well, so this is bovine discs. Bovine discs also have lots of these bacteria present, and this is a totally normal, non-degenerate disc. So what we really want to now look at is, are bacteria present even in juveniles, in fetuses? Do they appear during life? What bacteria are there? Are there different phylotypes? Is there actually a microbiome within the disc, and actually understand how this changes during degeneration? Unfortunately, Wellcome Trust turned my grant down, but I'll try again, but we'll see. So one of the other things that we're looking at in the disc is something called cellular senescence. So cellular senescence is cellular aging. So I've previously shown that in disc degeneration, you have this accelerated cellular aging within discs from patients with disc degeneration. So these are just two markers of cellular senescence, P16 and senescence-associated senescence-associated beta-gal staining, which is the little blue stains. So these are increased in degenerate discs. If you take cells out of age-matched, non-degenerate versus degenerate discs, the non-degenerate disc cells can grow for much longer, so they have this better capability for cellular proliferation. And also the cells from the degenerate disc show these shorter telomere lengths, which is your cell's normal control mechanism. So every time a cell divides, the telomeres get a little bit shorter, and when they reach a critical limit, the cell stops dividing, and that's there protective to prevent kind of mutagenesis and things. We also showed previously that actually if you look at some of these catabolic enzymes, they correlate really clearly with this senescent phenotype. Unfortunately, I didn't call it senescence-associated secretory phenotype, which now is well known within the field. This was actually shown before that was coined, but yeah, I should have called it that and I would have got way more citations, but anyway. So what we're looking at now is, can we try and target this pathway and prevent kind of that cellular aging or clear these aged cells from within the discs? Now, one of the things that occurs during these senescence is this increase in these enzyme production, and this is regulated through a pathway called C-gas sting. So the way this works is during kind of within a normal cell, if you get DNA damage, that DNA that should be in the nucleus is recognized by a protein called gamma H2AX, and this is upregulated in disc degeneration. This is then shuttled out into the cytoplasm by the cell, and we see within degenerate discs we have the presence of this cytoplasmic DNA. And this is recognized by C-gas, which is a small protein, again, upregulated in disc degeneration, and this causes activation of a pathway in the cell called the sting pathway. And this sting pathway causes activation of all these inflammatory cytokine production. So we can see that the C-gas levels correlate with senescence levels, which is P16, and also, again, we've got this gender difference. So C-gas is actually increased more in females than in males as well, so we're looking more into this as well. So senescence can be induced by kind of two pathways. One is replicative senescence. So as I said, every time a cell divides, telomeres get a bit shorter, and then it kind of effectively stops growing. And then also stress-induced senescence, where stress effectors such as cytokines or reactive oxygen species can cause DNA damage, inducing this stress-induced senescence. So what we're looking at the moment with funding from Versus Arthritis is whether we can either clear the senescent cells, so kill them off, and we can do this with agents called senolytics, which basically specifically target the senescent cells and kill them, or whether we can use the sting inhibitors that we've developed within our group to prevent the catabolic phenotype of these senescent cells. So this is work that's just started, so I've just got a little bit of data where we're looking at kind of the senolytics on human disc tissue, so we can grow pieces of disc tissue in the lab, and we treat them with these different senolytics, and this is just looking at overall metabolic activity. And what you can see is in some of the agents, but not others, we're decreasing metabolic activity. So what we're now looking at is that because we are killing off the senescent cells. So this is very early stage, and hopefully next time I can come back with some more data on that. So one of the other key targets in the process of degeneration is interleukin-1. And this is actually what my PhD was on too many years ago. So I showed that IL-1 was upregulated in disc degeneration, and this can drive all of the changes that you see in disc degeneration. So it drives nerves and blood vessel ingrowth, it drives the changes in the matrix, and it increases enzyme production. It can drive the production of cytokines and chemokines, and can potentially induce that cellular senescence. But the argument often was is that cause or effect? So what we looked at was in a knockout mouse model where you take away the natural regulation of interleukin-1, IL-1RA, here you see spontaneous degeneration. So we get an increase in all of the catabolic factors and also increase in cellular senescence as well within these mice, where the only thing you've done is take away the normal regulator of IL-1. So together with American company Parcera, who've developed a viral vector to deliver IL-1RA, we've been looking at whether this could potentially be used within disc degeneration. And I'm just going to show the explant work. So within here, we can see that the gene transfer can increase the levels of interleukin-1 receptor antagonists within the discs and promote normal matrix. So we get this increase in aggrecan, and we get a decrease in a lot of the catabolic things. So if you want to read more, that was published in Nature Gene Therapy late last year. So what about regeneration? So to regenerate the disc, we need to consider the low nutrient supply. So is putting cells in a good idea? We need to inhibit that degenerate niche. We need to restore the mechanical properties and actually be able to enable kind of regeneration within the tissues. So what we've developed is an injectable gel system, which is liquid above body temperature, and upon cooling sets as an irreversible gel. So you can see in a minute, we'll inject it into the little agarose block. We've added a red dye so you can visualize it, and it flows freely through a very fine bore needle, but as soon as it cools, it gels instantaneously. And this can be injected into human discs. So this is a human cadaveric spine disc where we've injected our gel system together with a radiopaque substance. So hopefully you can see a black substance filling into the disc, and this fills all the cracks and fissures within the disc tissue. So this is pre-injected MRI images of these cadaveric discs. So these are now naturally degenerate discs. You can just about make out the cracks and fissures. And when we inject our gel, it's filled all of those little cracks and fissures, so it almost fills all the little fingers. We see an immediate increase in disc height following injection and an immediate increase in the actual modulus, i.e. the mechanical properties of the disc. Now, of course, the last thing you'd want to do is once you've injected, the patient gets up and starts walking around. We don't want it to extrude out. So here we've done some failure testing on the discs to see whether or not our gel comes out. On the bottom one, we do actually induce a herniation with this. Remember, these are degenerate discs, but that herniation, which is about to pop out now, that was induced at a pressure that was 3 times higher than any physiological load the disc would have, and that was MP tissue, not our gel. So the gel didn't extrude, but the actual tissue did. And actually, the loads that the disc failed were kind of 10 times the level of normal physiology. So you'd have to jump off a 10-story building in order to induce that load. But that's very simple loading. What we've also looked at is more physiological loading, trying to mimic kind of tying shoes and sweeping the floor. So you can see much more higher forces. And again, the gel does not extrude. And we can still see it within the tissues following all of these different forces. We see that when we inject our gel, we get an increase in disc height and also a decrease in the range of motion, which is good for discs. You don't want them to be too flexible, so we're actually making it, restoring it back to a more normal state. And then we have also looked at multiple different cell types, and this review definitely refer you to in terms of which cell types might be possible. I'm going to whiz through quickly because a lot of this work's been published, but trying to combine different cells into our gel system. So the first one was bone marrow-derived and adipose-derived stem cells, or stromal cells. And we've shown that if you inject these into our gel system, the gel turns them into disc cells. We also have a bone gel for fusion. So if we look at the two different cell sources, PAX1, Aggrecan, COL2 are all disc markers. So both cell types can differentiate equally into disc markers. And then osteopontin is a bone marker, so our B gel introduces bone as well. A newer cell source we've been looking at is notochordal cells, which are your juvenile cells within the body. So we can also maintain their phenotype within our hydrogel system. But those aren't available within humans, so you have to get them from pigs. So we're also now looking at the potential of using induced pluripotent stem cells, which you can access easily, and our gel turns them into disc cells as well. So what about that native environment? Remember I said it was rich in interleukin-1. Well, our gel can inhibit IL-1 as well, so we decrease the levels of interleukin-1 and the receptor that it's expressed. And if we look within human discs, our gel alone can increase the matrix and decrease catabolism within human disc samples. Within a goat model where we can induce degeneration, apply mechanical loading, we've shown that our gel can restore and kind of regenerate that tissue, either with or without cells. So actually it looks like it's just as good without cells as it is with cells. So after 10 years of working on cells, it might be we can just do it without. But we do see that when we inject our gel, and you can see within kind of the line spaces, the native disc cells can migrate in, if I zoom in a bit better, and they produce matrix within there. They increase production of aggrecan and collagen type 2, and again, decrease this catabolic phenotype. But that's all in a goat model, so what about in humans? So we haven't got this in living humans yet, so don't get too excited, but back to kind of that human cadaveric model, where we've injected into the spines, we can actually see that in this human cadaveric model, where we then culture for a period of 4 weeks under a loaded system, when we've injected our gel, we see this apparent regeneration or repair even just after 4 weeks, with this total obliteration of the catabolic signals. So it's looking really promising. We've now taken this through to in vivo safety within sheep. I'm sorry, I'm running out of time, so I'm going to quickly whiz through. But effectively, there was no adverse effects within the sheep, and there was no immune cell activation. When we're looking at ALU sequences, because we've injected cells in, we see that the cells retained within the disc we've injected them in. And histologically, we're seeing filling of the voids within the degenerate model, and also increases in the production of the matrix, so aggrecan, and also potential decreases in those matrix-degrading enzymes within the sheep. And then finally, as I said, it's now been licensed to a company, Orphason. So they've been working on looking at cold injection rather than hot injection, because that's going to be easier for clinicians. So they've developed an injectable system which basically can force it through. And even using cold injection, it can still be injected easily through small needles, and you can see it really nicely within these MRI images. So I'd just like to finish by acknowledging all the collaborators, PhD students and postdocs that have worked on this, and of course, all the funders. Thank you.
Thank you, Christine. That was fantastic. We've probably time for one quick question for either Christine or Lee or Ashley. Yeah, thank you.
I'm Surendra Bande. I'm one of the consultants working in spinal injuries unit at Salisbury. Actually, I have 4 questions, but it looks like we don't have too much time.
I'll answer the rest outside.
Okay. Do we have any kind of idea whether the flora in the disc are anywhere related to the flora on the skin or gut, and whether probiotics have any role in disc?
So that isn't known at the moment. So certainly within the cow discs that we've looked at, we've done kind of more analysis, and actually a lot of the bacteria are similar to the ones that you find within the gut. That is something we want to look at within humans and do that direct comparison of what you find in the disc versus what you find in the gut and the skin, and see is there any associations. You do see differences as well from patient to patient, so do you see any commonalities across? Yeah. But we don't know yet.
Thank you. I'll ask other questions outside.
Thank you very much, Christine, Lee and Ashley. Thank you very much.
Welcome all. Thank you for joining us. This is the Vasquez presentation, and in keeping with the previous talk, this talk is also from Sheffield speaker. It gives me pleasure to introduce Mr. Pradeep Tumbikat. He is the network lead for the Northeast and Yorkshire Spinal Cord Injury Network, Rehabilitation Network, and he's going to share his views on efficient pathways. Thanks.
Right. Good morning. I think we've got a very small audience here, so but the problem I'm going to talk about is quite a big problem, and it is something that really holds up a number of hospital beds. And so I'm just going to talk to you about the issues with the spinal cord injury pathway and why, after many, many, many years of trying to change it and to improve it, it has not, it's not had the dramatic effects that we would like it to have. So I'm based at the Spinal Injuries Unit in Sheffield, and and I'm the network clinical lead for the Northeast and Yorkshire region, which covers 3 spinal injury centers, which is Sheffield, Wakefield, and Middlesbrough. And Helen Ridley, who's the network manager, was supposed to be with me, but she is indisposed and has not been able to make it. So she sends her greetings to all of you. So this is what the situation is in terms of the spinal injury units across the country. So there are around, between 385 and 395 operational beds around the country at any one time. And this is catering to the whole of the UK population. And while I'll focus predominantly on that area from the Scottish border to East Anglia, which is the area covered by the Northeast and Yorkshire network, I will touch upon some of the historical context and how we have got to where we are. And each of these units roughly cover between 8 to 15, 16 million population. So it's quite a large population that each of these units serve. So in terms of bed capacity of these units, it's not really changed. The overall bed capacity in the spinal cord injury system in 1982 is about the same as it is today. So there has really been no change. There has been an increase in the number of people with spinal cord injury for several reasons. One is, obviously, with an increase in population, there has been a proportional increase in the number of people with spinal cord injury. But also, in the years before 2010, non-traumatic spinal cord injury was never referred into the spinal cord injury system. So since that, there has been a massive increase in the numbers. So it has almost trebled, if not doubled, in terms of the overall referrals. And we've also got older people who are having minor faults. So there are a lot more older people in the population, and they are the ones who suffer relatively minor faults and go on to develop central cord type of injuries. And you've also got people with non-traumatic cause of spinal cord injury. So there's been a massive explosion in the number of people with discitis, people on immunosuppressants who go on to develop spinal infections, spinal strokes, you name it. There has been a massive increase. And alongside that, there's been a change in the profile of patients in as much as the male-female gender, which used to be about 80-20, is now somewhere between 70-30, 60-40, depending on the year and depending on which area you look at. And that reflects that change in the type of injury and the change in the traumatic versus non-traumatic balance. So this was a research report that was published by the Spinal Injuries Association in 2009. And you can come closer if you want. It doesn't read particularly well on this, but what it said at the time was that 10% of patients, this is in 2009, 10% of patients never got to a spinal injury center. 59% experienced significant problems, either immediately after the injury or later. And about 43% reported additional medical conditions. So there was major concern around access to spinal injury centers and how the spinal cord injury pathway was working. In fact, there were questions raised in Parliament, and there was a little bit of commotion around all of this. So, Spinal Cord Injury Strategy Board was set up, and a lot of work then sort of went on, and I won't go into that. It's quite boring. So, and it all came to a head in 2017, I think, when there was a National Service Review. And the National Service Review identified that there was a shortfall in the number of beds, that there was a problem with capacity. And based on that, it was suggested that a new spinal injury unit should be created. Now, that report was never released. And finally, the Health Services Journal, in 2019, I think it was sort of published, somebody leaked it, and it was published as a leaked report rather than an official report from NHS England. So that's the background to it. So in 2019, so just before COVID, and it was the last conference I went to, last large meeting I went to before COVID, something called the SCI Transformation Project was set up. And the idea was that around £3 million would be spent extra each year on the spinal cord injury service. And NHS England, in its wisdom, decided that it would be devolved to the regions and spent on a population, on a population basis, and different regions were allowed to evolve different models. And different things have happened across the country. But the whole idea was that so there is a problem, and something needed to be done to support patients before they came to the spinal unit, and something needed to be done around those people who did not get to a spinal unit. So that was the thrust of that. And yeah, so I won't go into the different models that have evolved. So this is what should normally happen. So ideally, we should just follow those green or the olive green boxes. You've got an acute injury or an acute non-traumatic problem. It's treated at a major trauma center or a teaching hospital. The patient then gets transferred to a spinal cord injury center, and they go through their rehabilitation process, and they're discharged home, or where discharged to a home is not possible, they're definitively discharged to a nursing home. But that is not what happens. Because of the various issues that exist in the system, what happens is patients wait at major trauma centers. They often get referred to, they get transferred to DGHs because there isn't a bed available. And if it is a ventilated patient, they will wait either at a DGH, on an ITU, either at the DGH or in a MTC. And then, not everybody gets to the spinal cord injury center. Some of them will get transferred to a local rehab unit, and some are discharged home without spinal cord injury input. Now, all of this creates a lot of additional work. So we are spending a lot of energy, and there's this whole thing about mantra about getting it right the first time. We are doing everything we possibly can to not get it right the first time, because we are going around in convoluted cycles of creating these holding points. And it reminds me of a Costa queue where you create these different stops so that somehow you create the impression that things are moving, whereas in effect you're still waiting about 20 minutes to get your coffee. Right. So what we don't have much of an audience, but I was hoping that there would be some spinal surgeons and so on. People constantly, I know my spinal surgical colleagues often are frustrated about the fact that people don't get to a spinal unit. But what is not realized is that all these holding points are effectively the dam spilling over. Because there isn't, if you've got a small dam, it's filled to capacity, and the outflow is poor. So the dam is just simply welling back, and people have to be accommodated somewhere, and that is why people end up staying at DGHs, staying at local rehab units. There are all sorts. So it is not an ideal scenario at all. So this is what happens. So, as I said, we have patients waiting in MTCs, in district hospitals. At least with MTCs, the advantage is that they are cohorted, and you can get a degree of expertise developing, within the staff who are looking after these patients, because they're usually on a ward, and there are some identified wards in most of the MTCs. And with the vent patients, they wait in ITUs, and then eventually they get to a spinal cord injury center. And then there is a delay in discharging them because of issues that I will come to. So to make a difference to the first 4 of these problems, so that is the acute flow, something has to happen at the at the distal end in terms of getting people out of spinal cord injury centers. And I'll come to some data that we have collected, which was the the message I wanted you to take home from this. And this is what a lot of people are doing, just trying to somehow move people on. And it is frustrating both to the clinicians at the front end and to those in the spinal cord injury center, because when people come to the spinal cord injury center, they have often developed complications. They have learned the wrong thing, developed abnormal patterns in terms of gait training and so on. And psychologically, they're not necessarily going through that adjustment period particularly well, because it's usually during those first 2-3 months when that adjustment process is happening that you really want people to be supported well. And often it's not just the professional support, which people do try hard. It is also about the peer support and the environment in which people are in. And so that is not working for patients. It's not working for all of the acute clinicians, and it's not working for the spinal injury centers. So where are the bottlenecks? So it is from the MTCs to spinal cord injury centers, for the ventilated patients from intensive care units to the spinal injury centers, and that is all arising out of discharge from the spinal cord injury centers. So, and then there is a further issue which arises when people who are living with a spinal cord injury want to get readmitted for problems. There again, there is a big delay in terms of how they can access the specialist centers. So these are some of the issues, and this will be familiar to you. I'm not going to go through this in any great detail, but what we do find is that preventable complications increase. There is a significant physiological impact in terms of the patients, and it creates a lot of work for staff who are not familiar with looking after people who are very highly dependent and who are very prone to complications. And then you get all the issues with delayed rehabilitation, incorrect compensation strategies, and a prolongation of the period that they eventually spend in the spinal unit. So in the northeastern Yorkshire, a network, as part of the transformation, a spinal cord injury clinical network has been set up. And that has been looking into some of these problems in a little more depth, involving all of the stakeholders, so not just the spinal units and the major trauma centers, but involving the specialist commissioners, involving the ICBs, and the local rehab pathways and so on, in terms of where the problems are and how it can be improved. So one of the work streams is this network and network pathway improvement work stream, and it has been looking at the discharge pathway, looking at capacity and demand, and also looking at specific problems in terms of the more incomplete patients and the older patients, looking at how readmissions can be delayed, and what percentage of beds within these specialist units are being used for readmission. Because when we calculate capacity and demand nationally, often the acute pathway is looked at in isolation without looking at the readmission requirements. So this is the data across the northeastern Yorkshire. So this is the 3 spinal units that I was talking about. And what you will find is that if you look at the 23-24, the large number of patients are above 50, and a significant number above 60, and also a substantial number above 70. So their ability to engage with the classical model of physical rehabilitation is not going to be quite so good as the models that were developed for the much younger spinal cord injured patients. So this is from the model hospital system. And what you will find is that, now this graph, for those of you who are working in major trauma centers, this is working, this laser. No, I don't think the laser is working. So if you look at the first graph, first table, what you will find is that although the expectation is that people are referred in at least within 48 hours into the spinal units, the average time to admission is sort of 15, 16, 17 days. And I don't think major trauma centers are quite so bad. There are delays, but I think most of this arises from the non-traumatics, where there can be a delay in diagnosis in terms of determining what is going on. And because they're often dealt with by neurology and cardiac and so on, they're not familiar with the pathway. So there is often a long delay before patients are referred in. So I think that I wouldn't take that at face value. I don't think the delays are quite as bad as that at the major trauma centers. And then you look at the time that patients are fit for admission to admission, and you'll find that there is significant variability between the units. But still, people are waiting quite a long period of time, which really shouldn't happen. So in the ideal world, you want somebody who's fit for admission to be admitted the next morning so that, one, the bed is freed up at the acute end, and two, the patients are not left in a holding pattern, which will sometimes be on totally inappropriate medical wards and so on. So that's there. And then when you look at the delay in discharge, so this is the last bar chart, is the fit for discharge to discharge. So once a patient is considered medically fit for discharge, how long does it take to discharge these patients? And we are talking about roughly somewhere between 1.5 to 2 weeks delay in a number of centers. And that is related to various aspects of sort of how patients leave spinal units. So this is a breakup of that, sort of the overall length of acute treatment and admission and rehabilitation. And if you think about sort of most levels, it is it's somewhere between 3 and 6 months, depending upon your level of injury. And you do have to remember that these are people who are like you and me, who are going about their normal life and suddenly end up with a life-changing situation. And that is the length of time that we are giving them. And there isn't really a mechanism for people to come back in to the system. And there is sort of a fairly strong sense within the user community, within the spinal cord injury community, that they are not getting that that subsequent access, which is often required to sort of effectively rehabilitate themselves. Yes, you can get them through the acute pathway and then discharge them. But what happens once they're discharged? Sometimes to inappropriate housing, sometimes to interim placements and so on. What does happen to these people afterwards? And it's not an entirely satisfactory situation. And so this is the number of bed nights lost due to delayed discharges. And across the 3 units that I'm talking about, 2,440 bed nights were lost last year, just due to delayed discharges. And this is 2,440 bed nights that would have been saved at the front end if the discharge delays had been eliminated. And the total number of patients that who were considerably delayed across the unit, there were 86 patients who were delayed in terms of their discharge. So you can see how, when we are dealing with a fairly small volume of beds, and with all these differing priorities, and then you get this delay in discharge, you are talking about a system that is going to struggle quite a lot. And this is an interesting thing. So Helen put this together. It's quite interesting. It's looking at each of the 34 patients who were delayed in Sheffield. Okay? So the yellow is the amount of time that that was required for rehabilitation, and the red is the delay. So if you look at that first patient, he needed about a week for rehabilitation. So he probably was a very low-level spinal cord injury who was ready for discharge in a week. But he spent the best part of 10 or 12 weeks just waiting for a discharge package to be put together. And you can see that graph that goes across the thing. So this is the situation in Southeast, where they have got a smaller bed capacity. So obviously, the number of delayed discharges will also be smaller. But again, the same pattern is thing. And this is from Wakefield, where they had some extraordinarily long delays. And these are the, so most of you will be familiar with what, what holds people up. But with this patient population, the issue is that the needs are far more complex than it is for, your average walking wounded person. And there is also a tendency for people to be discharged to interim placements. and for care requirements to be considered once they are discharged to those facilities. And the problem there is that you then lose out on all the specialist support that otherwise would have been available when determining a discharge package. So it's a bit of a cop-out by regions, and that again contributes to a lot of unhappiness. So this is the situation as of 7th of March. So this was a sort of a live data that we picked up on the 7th of March. And you can see that sort of across the 3 spinal injury centers, in Sheffield, there were 13 patients who were ready to be admitted, who were fit, and I think there were about 40 referrals, about 13 patients waiting to come in. They were already fit, medically fit. In Pinderfields, about 5, and in Middlesbrough, 2. And how many delayed discharges did we have on the same day on the unit? 7 in Sheffield, 5 in Pinderfields, and 4 in Middlesbrough. And if you add up all this, the differential is about 3. So technically, all these patients could have come on the same day without sort of a problem, but for about 3 patients, if the discharge process was working well. So this is a case study from, I'm not going to go into the details of this. It was sort of Glynis Pete from Middlesbrough provided me with this, with this rather stark example of, sort of what happened. So this is a chap who was injured on the 25th of July, 24, and his discharge date was the 12th of December. And then just because of arguments, I mean, you can read the thing, it's quite a sad story. And it was to do with who would provide for his bowel management when he returned to the community. So the argument was entirely about that. And that argument and the subsequent discussions delayed his discharge by 82 days. So close to 3 months, he stayed in a tertiary spinal unit, just waiting on somebody to sort out this argument about what should happen, who would do his bowel management. It was not a specific funding issue. It was not a specific thing. It was really about that inability to, sort of get their act together. So this is another one where the delay was 180 days. And so again, a very incomplete spinal cord injury, so a hyperextension injury, and his discharge date. So his injury was on the 28th of May. On the 5th of September, he was ready for discharge. Okay, and then various arguments about funding. Subsequently, the patient, and the family refused the initial offers that they were made. And I think eventually the trust had to take legal action to get him out. And that resulted in a 180-day delay. So 6 months of a tertiary unit stay, bed lost. So we are essentially using some of these beds as glorified nursing home beds. It is just not sustainable. It is just not appropriate. So this is what we found. I mean, on the ventilator, with the ventilated patients, it's even more complex. I'm not going to go into that because I just wanted to really give you a sort of example of the kind of things that happen. So in Sheffield, and these are sort of totally across the region, I think there are 7 beds which caters to ventilated, no, not 7, 8 in Sheffield and 2 in Middlesbrough, so 10 beds, which cater to people who are high tetraplegics, who are ventilator dependent. And last year, we lost sort of 1 full bed, so that's 365 days, just because of delayed discharges. And that relates to about 5 patients. So the problem is, you've got a relatively small dam, which is not, which is blocked. There is the water just cannot get out. And unless we do something to, sort of 1, increase the capacity of the dam, and 2, improve the, sort of the outflow gates, things are not going to improve. We are going to be talking about this, sort of 10 years from now. So in conclusion, I think there is a real capacity-demand mismatch, which results in a spillover with patients spending long periods at MTCs and DGHs. About a quarter of the limited capacity available is being lost through a delay in discharges. Okay, so from our 300 or 387 bed capacity, I think it is fair to say that about 100 beds are being lost because we are not able to get people out in time. And this calculation does not also account for the people who are readmitted. So again, depending on which unit you speak to, about 15 to 20% of beds are used for people who are being readmitted. So your overall capacity in the system, I would argue, is somewhere in the region of between 200 and 250 beds at any one time. And sort of over the last 15 years, there has been a considerable change in the profile of the patients we are admitting. And there is, again, like in many other services, I don't think this is unique to spinal cord injury rehabilitation or rehabilitation per se. There is no account really being taken of, one, their different needs, but also the length of time it takes for people to get up to the same level of independence. So if with a 22-year-old paraplegic, which used to be the classic example, sort of 25 years ago, you could get somebody rehabilitated physically, sort of completely independent in about 2 months' time. Okay, so they would be well functioning from a wheelchair. If you took the same level of injury, the same density of a neurological deficit, and applied that to a 70-year-old man, the amount of time it will take to get that man to the same level of independence, if he ever gets there at all, would probably be 4 or 5 months. So there is a major physiological difference. And also, when we deal with people who have got incomplete patterns of spinal cord injury, again, they take more time. There is more customization required in terms of, sort of the rehabilitation package, that they require. So, again, I don't know how many of you are involved with this, with spinal cord injured patients. And I just, I would be very curious to hear about your thoughts and observations on sort of what I've just been through. And this is some preliminary data. I think over time we will get much richer, much granular, sort of more granular data. But it's going to say the same thing. I mean, I don't think, sort of the situation has changed massively over the last 15 years, and I don't think it's going to immediately change. So we need to really start thinking about how, as across the whole pathway, sort of at the acute end, at the sort of the middle where the spinal cord injury units are involved, and as people leave hospitals, that sort of everybody thinks together in terms of how these pathways can be improved. Thank you.
Thank you.
Thanks, Pradeep. Alistair Hudd, Ipswich. You talk to my colleague David Cumming all the time about this, and obviously we're about as far away as you can get for your catchment. We're very thankful for it. And we obviously split. We service a third of the east of England, and half of ours go down to Stoke Mandeville, and the rest comes home. And if Stoke Mandeville were giving the same talk, I'm sure it would be worse judging on how our patients flow in both directions. Something that you all know we have done is the transformation budget that we got given. We've heavily invested in spinal cord injury link nurses and specialist physios who are purely there in our unit to look after cord injured patients. And we have found, actually, I was interested, you may need to put an extra little box as to flow as to what happens to your patients. We got to a stage, not with Sheffield necessarily, but we've got to a stage where our nursing and therapy staff have done such a good job in-house because of the waits to get into our cord injury centres, that we've got patients that should have gone to cord injury centres that are now going home and then having outpatient cord injury. These are Asia Ds and even some of the Cs that have converted into Ds because of the wait. But we've used that money, rather than there being a cord injury centre put into the east of England, which was deemed too expensive by the government, the money has kind of been flown into staff. But that's how we've kind of adapted to the problem of what to do with those patients that are kind of stuck in the MTCs, DGHs. But I entirely agree that the problem appears to be that ours are waiting because there's not enough getting out the back end.
But you also make a very relevant point, and I agree. It's about creating capacity, but effectively what you have done there is created some capacity. I mean, Manchester has done something similar in terms of creating about 6 or 7 beds within Salford Royal. And in St. George's, they keep a few patients sort of, again, in a cohorted area. But I think indirectly and surreptitiously, what we are doing is we are creating that capacity. And the only question, I mean, as a sort of professional grouping, and from a commissioning end, is really to ask the question: is that the most effective way in terms of the patient outcome and patient quality, or do you cohort all of them and say, right, in East of England we will create a sort of a separate unit? I mean, that's a separate question. I mean, that's not, we can't answer that question. But the point I think I was trying to make is that somehow or the other, we are creating this capacity. It may be sort of labeled as such, but in many cases it's not labeled as such, and you're not necessarily paid at that higher level for looking after those patients.
No, we're not. You're entirely right. And you're right, some units are only putting aside a few beds, like there's a finite number of beds. We're rolling a different model where essentially the team will look after any cord injury in our region. So sometimes we've only got 2 or 3, but we've been up to 12, 13 acute cord injured patients that are just looked at. And we flex. We're lucky we can flex with our TNO colleagues on our trauma wards to do that. But it is a significant burden, and it does require building a team that can look after these patients.
And that's my point. That sort of if this need is acknowledged properly, and if it is properly funded for, you would be able to develop a team that that's got all the relevant bits to ensure that the patient is sort of adequately supported, not just in terms of medical needs, but all of the other softer bits that go into what is a well-rehabilitated individual.
A lot of this is not the medical or surgical. Very much it's our specialist therapists and nursing staff that with a spinal cord injury link interest that are really the drivers and the difference for these patients. Thanks.
It's a very good model.
Yeah, hi Pradeep. Yoon from Leicester and Nottingham. So you're our patch, Pradeep. So one of the things, I completely agree with that last person. We've got the same peripatetic team that we're setting up now, but that's more of a reflex to the problem that we're having. And I think the answers or the question that you've posed is what are the solutions? The solutions are either, in my eye, we need more capacity for spinal cord injury beds, which I'm not sure I understand from an NHS England perspective what the blockers are from that. Okay. The other thing is also, do we need more spinal cord injury centres, period, in the UK? Because obviously I worked in Australia as a trauma consultant and spinal consultant, and every hospital pretty much that does trauma has their own spinal cord injuries unit on the site. Okay, as far as I'm concerned, obviously Stoke have it, Sheffield have one on site. You've got some over in Norfolk and Norwich, I think, has got their own, or in
Midlands, I think Oswestry has it.
No, so the only 3 centres which have it on site are Sheffield, Middlesbrough, and Glasgow have it sort of co-located alongside the MTCs. Everywhere else, the spinal centre is separate to the MTCs.
So, a lot of the stuff we're doing is, as I said, a reflex to try and improve what we already have. But I think there needs to be some stakeholder meeting, maybe with the guys in region, because I know the Ipswich guys with David Cummings and you guys, we function pretty well in our networks. But I know other networks, Sheffield, for example, does not function so well in their network with spinal injuries. So, it's probably, I don't know where would be the best forum to sit down with those people to see what can be done. There are a lot of things that are happening. As you know, there's obviously, I'm ex-military, you've got the military NRC, right? But my understanding is that is, again, not clear-cut to be made into I'm not quite sure why that is. People don't want to talk about that topic at all.
So I think to some extent this is political and financial in terms of, when you cut to the chase, because in 2017 it was clearly evidenced, because it was a national service review, And the recommendation was very clear that we needed about 90 more beds, which after NHS re-looked at the data, said, oh, we can manage with 52 beds or some such thing. And most of that need was in the southeast of England, because that's where, because if the southeast of England gets a little decompressed, then it will open up access at Stoke Mandeville and to some extent at Stanmore and Sheffield. So that was the logic at the time. But it wasn't, it just did not get through, and in fact the report did not get formally published. So I think it requires a little more, I don't know the answer to this. I think that evidence is out there.
I mean, it's possible that we can sit down. If you want to join us in our network meeting, we can put together an analysis that will highlight maybe benefits, but there needs to be probably some thinking about what you want. Do you want more beds to be made in Sheffield, which is absolutely fine. Well, as clinicians, we're very much advocates for our patients. Obviously, I understand there's a huge political tension between various areas and who takes ownership of spinal cord injury and stuff like this. However, as you know, 180 days in hospital is not the best way of doing it, even though you have got specialist nurses coming on now looking after patients. But no, I'd like to have that conversation. If you want to join up, Pradeep, we can.
I very much appreciate that. But also, I think there is a Midlands network. I mean, I don't know how closely this surgical network is tied into it, but there is a formal NHS England Midlands network.
Yeah.
Which I think some of your colleagues from Derby attend on a regular basis.
Yes, so I'm the medical lead of that.
Yeah.
So Derby do, for sure. So Derby, Leicester and Nottingham, we all have a board meeting once a quarter, and we have regular monthly meetings to discuss this. But because we can help, the funding we've got for our paraprotective nurses are through that network from NHS England. So, I mean, this is something that I think in the next 10 or 15 years there will be opportunities to be had. And I think now is probably the time, as you say, to talk about it.
Yeah, and there's also Michelle in the audience who is very much from the Midlands and who knows the situation there well.
Just last point, please.
Yeah, just so it is clear that discussion was had, I have no political affirmations, you'll be glad to know. It was a purely political decision. The clear and common sense answer was that another unit or two needed to happen in the south or east of England. It was too expensive for the government. They chose the other option, which was to push less money into the regions that are pushing patients to the existing cord injury centres to try and find their own local solution. And that's all it is. So the discussion happened back in the SCI transformation 2017, and the government aren't going to currently change. It's a new government, I suppose, they might do. But that was the decision, just so everybody understands that it was a very clear-cut political, you ain't getting the money for a new cord injury centre, you're going to have to sort it out yourselves. And here's a smaller pot of money that we can just about afford.
Yeah, and just to sort of the final point on that is, it'll be interesting to see sort of in a few years when we look at outcomes in sort of across, sort of amongst people who are treated outside of spinal injury centres versus within spinal injury centres, it will become clear that there is a differential in terms of how these pathways are working. But I think at the moment, without capacity and without smoothing flow, I don't think we will get over this particular problem.
Yeah. The only thing I was going to say to that, I don't know if there's any way that we can push the commissioners or anywhere within NHS England to say that how can they repurpose or look at the funding streams for the local rehab centres, because if they can't go to Sheffield, and could sometimes that they actually get too good to go to you anyway, but they've got to have an alternative neuro rehab pathway, and sometimes our local centres are more than adequate to deal with their needs, because obviously they've not got any bladder or bowel and they've just got some neurological deficits in terms of function. But at the moment there is a big gap between your level 2A and your level 2 rehab beds, but I don't know if there is any way that we can help push that to say we just need to redistribute the money or the funding to where these patients can go as an alternative, because that shouldn't cost more. We're just looking at how we would repurpose the funding streams.
Michelle, no, I'm very mindful. Thank you for making the point, and I'm sure people have lots to discuss, but I'm also mindful about the time. So it is break time. Thank you all for attending, and please carry on the conversation after the session.